here's the other challenge. Chris, I saw a new piece of literature come out, for a condition that I'm going to start treating, whatever the case may be. Can we create that? And the answer is yes. Like I would probably never buy a device that didn't allow me to manipulate that. At least in the clinic unit, I get some of these portable ones that can be nicer, to just press a button. And we still have all that as well. So the parameters, when it comes to both laser and shockwave, we're looking at an energy or an energy density. We're looking at a frequency setting, and we could be looking at the total time or the total energy, which in the case of laser is going to be in joules, and in shockwave, it's going to be the number of impulses. And obviously they overlap to give us the energy flux density, the amount of energy that's going to be delivered to the target tissue over that general time frame. Now, the cool thing is there's not a lot of parameters that we really need to think of. The uncool thing is like laser is a little bit more challenging. So I had someone ask me about, oh, I don't need presets because that means I'm not a good clinician if I don't know which one to use. I'm like, yeah, you just really kind of need more of a basic understanding in terms of more energy, less energy. Do I need a frequency setting? Do I need it to be continuous? What are your wavelengths? What are your favorite wavelengths? What do you want to use for various types of conditions, right? Knowing the 4011 protocols that I developed for the products doesn't make you a good laser clinician. It makes you a laser specialist, which is a little bit different. But with Shockwave, it's a little easier. Um, but even then, it's not specific to a tissue right now. And then, well, what if the literature is in bar versus millijoules? That's where it gets challenging because bar is a pressure setting, right? It's a conversion of like PSI. So 1 bar is the equivalent to about 14.95 PSI. So that's just a pressure setting as it's coming out of your device. That actually doesn't necessarily translate into the tissue. Now, if you have an understanding of your device and you know the surface area and the actual force that it's producing over a given surface area of your applicator head and over the tissue, then you could potentially calculate your energy flux density. Yeah, most of us don't really do that, and so we kind of just go. At least today, we're still seeing that patient tolerance is a really good indicator of the potential higher end of the benefit, right? So that's sort of the upper echelon of the spectrum. And then what do we know below that? Well, we actually know that you do not need a lot of energy to create a biological response to the tissue. And that's very important to understand because, what I say is you don't have to kick the crap out of your patients just because, the literature is such. I was giving a presentation to a sales group on cervical traction, for example. And I'm like, yeah, you can start at 8 pounds, in a low coefficient friction design system. And everyone was freaking out because they're like, well, Medicare requires it to be. Blah, blah. I'm like, yeah, you can progress to that. You don't have to start with that because that might actually put them over the edge. If you hit someone too hard with these devices, you can flare up. They may not like that. So we can actually use a stepwise approach, which we'll look at here in a second. This is quick and dirty. So this is looking at what does a bar setting look like? And this is the linear translation. And so at zero point 0.5 bar, that's about the equivalent of 20 millijoules in most of the electromagnetic devices. So what we see is the pneumatic devices tend to use a bar setting. As I mentioned, that was PSI conversion. And the electromagnetic devices, it's easier to calculate because we're dealing with energy conversion. So I can actually use millijoules, and that makes it a little bit easier, right? So this is not. I don't want to mislead you. This is not a complete true conversion because there are other factors related to that, which is going to be the size of the surface head. Even the pneumatic devices, not all of them are created exactly equal. So this is the ladder I was talking about. I typically start with 500 impulses, and that drives people crazy. And they're like, well, that's not enough to do anything. Typical response is, oh yeah, why not? And they can't answer that. And you can't answer that because you'd have to quote literature, and the literature will show you that, it does not take a large volume of pressure to create a biological response. In fact, one impulse will do something. Now, is that enough to do something that we're looking for clinically? Probably not. But 500 impulses is really good opportunity to, one, be clinically relevant, but also test the waters. I never want to make it worse on a patient because then they have a tendency not to come back, right? So remember that whole relationship and that rapport thing that we want to deal with. So typically, we're going to increase in the volume, the number of pulses, before I'm going to increase in the intensity, right? So this is what I'm getting at here. Treatment one, 500 impulses, 60 millijoules at 12 hertz. Then I'm going to go to 1,000. Then I'm going to hit my target. Usually within 3 visits, that's going to be my target. And typically it's 2,000 impulses to 2,500 impulses. Okay. Now I can increase with the energy density. So here's what's interesting too, and why this I think is important to explain this to patients is, um, yeah, you're increasing, and that's actually clinically relevant. And you can say, well, how is that clinically relevant? People that are in chronic pain, we know that there's a decrease in the threshold at the DNA level to nociception. So when I can increase the intensity and not have side effects to that, it also means that we're literally changing that threshold, and that's clinically relevant. And I explain that to the patients because now in their mind they're thinking, oh, I am getting better, right? And it's kind of tying back in one aspect that they're at least thinking about, which is, oh, I'm out of pain. Now it takes me more energy to put me back in that same pain situation. So now my tolerance, right, per load is actually going to be increasing. So the stop rules are when we start to see these repeated flare cycles. And again, sometimes you don't know, and that's why we don't just have this steadfast rule of all these protocols. You might have someone who's more sensitive. You might have someone who's also, I won't say on an anticoagulant, but something that might affect. And let me tell you, it's not just anticoagulants that can affect that, but all kinds of medications can have an influence on what might result as a flare up. So we always go back, we reassess, we look at our targets, and we think about what it is that we're doing. So then for laser, we might do a couple things. I could potentially increase the energy density, right? So a lot of these devices have presets. I often start and I do a half to kind of develop and see. Now, again, it's a high intensity light, and so do you know if they're photosensitive or not? I mean, obviously, we're going to ask them. Sometimes people don't know till after they've been treated. Sometimes, yeah, we told them not to put any lotions or things like that on. So we can start with a lower energy density, and I promise you, relative to the lower power lasers we used to use, cutting a treatment protocol in half is not a bad start, right? And again, I don't overemphasize the whole pain thing. As you might imagine, I talk more education wise and explain to them, why we're also doing that, right? So we may increase the area, especially if we're dealing with the pain in the early stages, and then we actually tighten it. We stick to the pathology. As I kind of tell people, like, think like a surgeon when you're using, laser and shockwave beyond that pain level, right? And really just address that tissue, right? Because you can use some higher energy densities. It's going to decrease your treatment time quite dramatically. But what about these secondary areas? And this goes for both laser as well as shockwave, right? The typical, like I'm treating a lateral epicondylopathy, I'm treating over, where do I do? Over the boo-boo, right? But it's not uncommon that they have some issues going on in adjacent structures, maybe the wrist extensors, for example. That's where I may go off and do an adjacent area with the same device, or at least addressing those devices a little bit different.